Hey guys, ASMR. Wala ko patulog. We're gonna be talking about
A boring topic.
God, I wish I never spoke. Now I gotta wash my mouth out with soap.
Hi guys, welcome back to our channel. I'm Aliana.
and I'm Micah, and today we're gonna be talking about a very educational topic.
It is idiopathic frozen shoulder. What is idiopathic frozen shoulder?
Frozen shoulder, also known as adhesive capsulitis, is a condition characterized by stiffness and pain in your shoulder joint.
Signs and symptoms typically begins gradually, worsen over time, and then resolve, usually within 1 to 3 years. Stages of idiopathic frozen shoulder.
Stage 1. Characterized by a gradual onset of pain that increases, loss of external rotation, rotator cuff, and duration of this stage is usually less than 3 months.
Stage 2 or freezing shoulder. Characterized by persistent and more intense pain even at rest. Motion is limited in all directions. This stage is typically between 3 and 9 months after onset.
Stage 3. Frozen stage. This stage occurs between 9 and 15 months after onset. Characterized by pain only with movement, significant adhesions, and limited glenohumeral motions.
Stage 4 thawing stage. Characterized by minimal pain but significant capsular restrictions from adhesions. Motion may gradually improve during this stage, but this stage lasts from 15 to 24 months after onset, although some patients never regain normal range of motion.
Physical examination. Warm up or tissue preparation.
Hat packs. Hat packs to relieve shoulder pain. If you use these kinds of packs, it's important to protect your skin from extreme temperatures. For instance,
Fatigue
by using a towel.
exercises.
Shoulder flexion and extension. Hand placement and procedure. Grasp the patient's arm under the elbow with your lower hand. With the top hand, cross over and grasp the wrist and the palm of the patient's hand. Lift the arm through the available range and return.
Extension or hyperextension of the shoulder. Position the patient's shoulder at the edge of the bed when supine, or position the patient side-lying, prone, or sitting.
Shoulder abduction and adduction. Hand placement and procedure. Use the same hand placement as with flexion, but move the arm out to the side. The elbow may be flexed.
Internal and external rotation of the shoulder. Abduct the arm to 90 degrees and the elbow flexed in 90 degrees. Make sure that the forearm is held in a neutral position. Hand placement and the procedure. Grasp the hand and the wrist with your index finger between the patient's thumb and the index finger. Place your thumb and the rest of the fingers on either side of the patient's wrist, thereby stabilizing the wrist. With the other hand, stabilize the elbow. Rotate the humerus by moving the forearm like a spoke on a wheel.
Shoulder horizontal abduction and adduction. To reach full horizontal abduction, position the patient's shoulder at the edge of the table. Begin the arm either flexed or abducted 90 degrees. Hand placement and procedure. Hand placement is the same as with flexion, but turn your body and face your patient's head as you move the patient's arm out to the side and then across the body.
Cool down.
Shoulder hyperextension. To increase hyperextension of the shoulder, stretch the shoulder flexors. Patient's position is in a prone position. Hand placement and procedure. Support the forearm and grasp the distal humerus. Stabilize the posterior aspect of the scapula to prevent substitute movements. Move the patient's arm into full hyperextension of the shoulder to elongate the shoulder flexors.
Shoulder adduction. To increase adduction of the shoulder, Hand placement and procedure. Abduct the shoulder to a comfortable position, initially 30 degrees or 45 degrees, later to 90 degrees. Flex the elbow to 90 degrees so the forearm can be used as a lever. Grasp the volar surface of the mid-forearm with one hand. Stabilization of the scapula is provided by the table on which the patient is lying. Externally rotate the patient's shoulder by moving the patient's forearm closer to the table. This is fully lengthens the internal rotators.
Shoulder internal rotation. To increase internal rotation of the shoulder, stretch the external rotators. Hand placement and procedure. Abduct the shoulder to a comfortable position that allows internal rotation to occur without the thorax blocking the motion, initially to 45 degrees and eventually to 90 degrees. Flex the elbow to 90 degrees so the forearm can be used as a lever. Grasp the dorsal surface of the mid-forearm with one hand. Stabilize the anterior aspect of the shoulder and support the elbow with your other forearm and hand. Move the patient's arm into an internal rotation to lengthen the external rotators of the shoulder.
Hi guys, welcome back to our channel. So now we're currently in the library. Hi guys. ASMR. Wala ko patulog. Ay, ito, sige. ASMR.
Okay.
So guys, we're very sorry about the audio quality of this video because
We're at the library right
Yeah.
now studying.
as physical therapy.
We need to study some books that we need to read.
So go to the
Yeah.
library.
Let's go.
In summary of today's vlog, we tackled about idiopathic frozen shoulder. It's a condition characterized by stiffness and pain in your shoulder joint.
There are 4 kinds or stages of IFS. First is gradual onset of pain that increases. Second, freezing shoulder. 3, frozen shoulder. And lastly, thawing stage.
In this case, our physical examination is movement analysis and palpation of the shoulder.
The tissue preparation that we choose is hot packs for the tissue to loosen up, but precaution should be followed.
In this video, we also did passive range of motion exercises like abduction, and external and internal rotation and more.
Lastly, cool down. We did 3 stretching strategies to allow the body to gradually transition to a resting or near resting state. So we hope you'll be watching our next vlog.
Okay, so if you like this video, don't forget to give it a like
Comment
and subscribe.
Again, I'm Aliana.
And I'm Michael.
Bye.